How many people feel like the women who come in with recurrent UTIs are very distressed and they leave with a very satisfied visit, right? That's actually a little bit beyond the scope of this guidelines, but it is important to have this information for that sort of patient-centered discussion. And I think when you do that, they will walk away with a little bit more of that satisfaction. So it's education, and it's that shared decision-making, coming together with a plan, directly addressing their concerns and needs. But I think first and foremost, we have to arm ourselves with the evidence so that we can be the experts and lead and guide them. So here are my disclosures. So the learning objectives include reviewing the recently released in May of 2019 guidelines on recurrent UTIs in women. We're going to summarize the evidence underlying these guidelines as well as some important concepts. And we're going to discuss the relevance to some clinical scenarios. So the AUA guideline was a collaboration of the AUA, the Canadian Association, and the SUFU. Was led by Jennifer Enger and Toby Chai were the chairs. And I was fortunate to be a part of this group. So as we know, UTIs are prevalent, costly, and burdensome. The majority of women will experience an acute UTI in their lifetime. Many times they will have a UTI and then subsequently have another episode. And some of these women will then go on to have multiple recurrent episodes. The evaluation and treatment of UTIs is costly, up to $2 billion a year in the US. There's been a significant growth of antibiotic resistance in the last 20 years. Interestingly, the women who get recurrent UTIs tend to have treatment that doesn't adhere to the guidelines, whether they're pushing or people are kind of going beyond the bounds. So we would encourage people to stay within the guidelines for these patients. The need is to decrease the risk of antibiotic resistance, reduce the adverse effects of antibiotics, provide guidance on antibiotic and non-antibiotic prevention strategies, reduce the recurrence of UTI events, and improve clinical outcomes and quality of life for these women. So as I said, it was a collaborative guideline committee, and we wanted to define the evidence-based management in healthy female patients with recurrent UTIs and establish guidelines for the evaluation and management, as well as evaluate treatment and preventative interventions. So the study population in this group was an index patient, an otherwise healthy female adult with uncomplicated recurrent UTIs. The infection is culture proven and associated with acute onset symptoms. This excludes pregnant women, immunocompromised, anyone with any anatomic or functional abnormalities, people who self-cath or have indwelling catheters, systemic bacteremia, diabetes, spinal cord injury, and peripheral neuropathy. So interestingly, that's a lot of our urologic practices, but we had to start with the healthy population first. We did not discuss the prevention of UTI in the procedural or operative settings. So by definition, we had to define what a recurrent UTI is, and we used the definition that was most commonly used in literature, 2 episodes in 6 months or 3 episodes a year. Uncomplicated, again, refers to no anatomic or functional abnormalities, no immune compromise, and no multi-drug resistant bacteria. So a systematic review is performed, a literature search, there was criteria for inclusion, exclusion of studies, data was extracted, the risk of bias was assessed, and the data was synthesized and the body of evidence was rated. So this is the same evidence strength that's used in all the AUA guidelines. On the left side is there is a strong recommendation, a moderate, conditional, clinical principle, or expert opinion. And then across, it's the evidence is either strong, A, B, or C. So I reordered the guidelines from strongest to decreasing. So our strong recommendations were that, number 1, and clinicians should not treat asymptomatic bacteriuria in patients. This was a grade level evidence of B. For antibiotic treatment, clinicians should use first-line therapy. This includes nitrofurantoin, Bactrim, and fosfomycin, dependent on your local antibiogram for the treatment of symptomatic UTIs. And this was also evidence grade B. Moving on to moderate recommendations, clinicians should obtain urinalysis, urine culture and sensitivity, for each symptomatic acute cystitis episode prior to initiating treatment to patients in recurrent UTIs. Clinicians may offer patient-initiated treatment, also called self-start treatment, to select recurrent UTI patients with acute episodes while waiting cultures. And clinicians should omit surveillance urine testing in asymptomatic patients with UTIs. As far as antibiotic treatment, clinicians should treat recurrent UTI patients experiencing acute cystitis episodes with as short a duration as possible, generally no longer than 7 days. Some more moderate recommendations. As far as antibiotic prophylaxis, following a discussion of the risks, benefits, and alternatives, clinicians may prescribe antibiotic prophylaxis to decrease the risk of future UTIs in women of all age previously diagnosed with UTIs. And as far as the topic of estrogen, in peri- and postmenopausal women with recurrent UTIs, clinicians should recommend vaginal estrogen therapy to reduce the risk of future UTIs if there's no contraindication. So moving on to some conditional recommendations, clinicians may offer cranberry prophylaxis for women with recurrent UTIs. This is evidence level grade C. As far as clinical principles, in the evaluations, clinicians should obtain a complete patient history and perform an exam in women presenting with recurrent UTIs. To make a diagnosis of recurrent UTIs, clinicians must document positive urine cultures from their prior symptomatic episodes, and clinicians should obtain repeat urine studies when initial urine specimen is suspect for contamination. Moving on to expert opinion, and we are going to get to a case that'll discuss these more. Cystoscopy and upper tract imaging should not be routinely obtained in the index patient presenting with recurrent UTIs. In antibiotic treatment, in patients with recurrent UTIs experience acute cystitis episodes and associated with urine cultures resistant to oral antibiotics, clinician may treat with a culturally directed parenteral antibiotics for as short as duration as possible, generally no longer than 7 days. For a follow-up evaluation, clinicians should not perform a post-treatment test of cure in asymptomatic patients, and clinicians should repeat urine cultures to guide further management when UTI symptoms persist following antibiotic therapy. So we're going to start with a case, but I do want to mention the AUA guideline document is online and freely available. I would encourage you to read it. There's just a wealth of information in there. So we're not going to get to everything in there, but I think we're going to highlight some of the key points. So we have here a 35-year-old woman with recurrent UTIs. She has recurrent episodes of dysuria that are associated with sexual activity. She typically goes to an urgent care. She gets a UA in culture and is treated with antibiotic. Her cultures are typically E. coli with a greater 100,000 colony-forming units. Her episodes resolve with urine antibiotics and no symptoms between infections. So what parts of her history are important and what are next steps? As far as her symptoms, dysuria is the mainstay in the diagnosis of UTI. An acute onset, generally less than 1 week, of dysuria or fever and associated with other UTI-specific symptoms. These can include hematuria, new or worsening urgency frequency, incontinence, and suprapubic pain. I think part of our job is to educate women on what a UTI-specific episode is, or symptom-specific episode is, because as you know, some of them will come in and say, I have an odor, or my urine's cloudy, I know I have a UTI. Well, do you have any symptoms? Oh, no, but I know I have a UTI. And so I think we can, educate women, and certainly once you educate them, they realize that they don't really want to take antibiotics all the time. So I think really teasing out their symptoms or educating your nurses and your staff to do that, I think is very important. So there are obviously many non-specific symptoms. A big patient population that overlaps with this is the OAB population. They have urgency, frequency, and incontinence all the time. And so how do you distinguish between their UTI symptoms? Is it worse than your baseline? Is it acutely different? Oh no, it's the same, but I just thought. So there, and then the tough one is this general sense of lack of well-being. Certainly women say that they don't feel well, they have fatigue, malaise, weakness, but if that's the only symptom, they should be worked up more broadly. The challenging one is the 80-plus-year-old woman and the family comes in and she's out of it. I know she has a UTI, or does she have a UTI? And certainly, she doesn't have any symptoms, but what's the benefit, what's the harm? And I think that's a discussion, certainly to have with the patient and the family. So diagnosis. For acute onset UTI symptoms, this should be in conjunction with a laboratory detection of a uropathogen in the urine. So urine culture, traditional urine culture, is the mainstay of diagnosis during an acute episode. There are molecular diagnostics that are on the market now, and certainly we know a lot more about the microbiome of the lower urinary tract. And this bacteria, this normal flora, may be protective of future episodes. And so we don't really know what the role is of these sort of high throughput sequencing, these PCR-based methods. Have you seen these reports? They're like completely, I mean, very detailed, every pathogen you can known to man, and they have all of them. They're nearly all positive. So, certainly we want to advance the technology of diagnosis and evaluation of UTIs, but the role of where this fits in is not yet to be determined, as the studies have not been done. And so the guidelines could not recommend this for general clinical practice. So you can use your best judgment there. There was a big discussion about antimicrobial stewardship and the consideration of collateral damage. This is, certainly big in the entire medical community. So we've got to reduce inappropriate treatment, decrease broad spectrum antibiotic use, appropriately tailor necessary treatment for the shortest duration in order to prevent future resistance. And collateral damage, that's a very important concept because there are downstream effects of people taking antibiotics. They're altering their gut flora, they're selecting drug resistances. There's a lot of fascinating biology and studies on this. Some interesting studies on the increased C. diff in the UTI patients based on their antibiotic choices. So something considered certainly to follow and talk about with your patients. So we're going back to our case, the healthy 35-year-old woman. Guideline statement 1, clinicians should obtain a complete patient history and perform a pelvic exam. So she's had 2 children, she's otherwise healthy, she's on oral contraception, she has normal external genitalia and no periurethral pathology. Does she need any imaging or further diagnostic testing? So guideline statement 4, cystoscopy and upper tract imaging should not be routinely obtained in an index patient presenting with a UTI. But then she's like, oh, I did have that sling surgery 2 years ago, and my UTIs actually have increased since then. Does that change her workup? So if there's a clinical suspicion of something anatomic potentially contributing, certainly this is the AUA sort of algorithm, and one of the areas of it, sort of the top and to the right, says you can consider additional evaluation, upper tract imaging, cystoscopy, urodynamics, based on your clinical suspicion. So it's not required in all people. The yield for that is certainly very low. As you know, patients do get some reassurance from that, but the data does not support that. So in her case, you could discuss whether or not she needs that, and certainly a cystoscopy could be considered. This is sort of what we talked about at the beginning of the talk. You go into her history and what she's dealing with, and she talks about all the sort of the psychosocial impact of recurrent UTIs. She has a lot of fear, and the fear of what is this doing to her health. Women carry a lot of guilt and shame, and it just has there's a high amount of distress onto their quality of life. And so I think this is an important place to certainly reassure them that it's not something they're doing. There's a lot of talk about wiping and what you're doing and perinatal hygiene, and I think that it translates to the women. Sometimes they feel judged and they feel like you're telling them that they're bad, but really I think it just is a supportive, understanding conversation. You can certainly talk about the risks of antibiotics and the natural history of UTIs. There's a very low risk of progression to pyelonephritis in an anatomically healthy person. Also, there are times when you can counsel them that there are times when you're going to have UTI-like symptoms that are mild, and they will self-resolve with supportive care measures. There's been studies on ibuprofen, certainly water, use of pyridium. So you can counsel them that there are some self-care measures that can be taken that are healthy and supportive. Is this something that you experience in your practice, this level of distress? Okay, people are nodding their head, yeah. So again, a different topic, but there are things that we can do to better meet their needs, and I think it just has to go with what are their true concerns. Are they concerned they have cancer? Well, then you can reassure them about that. Are they concerned that there's long-term consequences? You can reassure them about that. So going back to the guidelines, she's like, what can we do now? Clinicians may offer cranberry prophylaxis for recurrent UTIs. So she's like, you know what, after our talk about the antibiotics, I don't really want to go there, but what other things that we can do? So you have a discussion with her. She opts for hydration and a daily cranberry tablet with 36 milligrams of PACs. She asks if she should add any other supplements. So to review the data on cranberry, I think this is a very popular and important question. The mechanism of action is that the PACs prevent the adhesion of the bacteria to the urothelium. The thing is that these PACs are in various concentrations based on the formulation used. Supplements aren't regulated by the FDA. They're sort of over-the-counter products, so you don't really know what you're getting. And so you should try to encourage them to get a high-quality product. This is very low risk to patients. They like it. They like doing something natural. However, there is some GI distress, certainly, and sugar associated with cranberry juice. There were 8 randomized clinical trials, juice, cocktails, and tablets. If you look at the data, if you're comparing these 8 randomized clinical trials of cranberry to nothing, meaning placebo or no cranberry, you actually decrease the risk, okay? If you look at cranberry compared to antibiotics, the difference is less clear, and it actually favors antibiotics. So it kind of puts that into perspective. There's probably some validity to it, but just because of the heterogeneity of the studies, some studies are going to say cranberries don't work, some are going to say they do, and so that kind of puts into perspective. Patients like it. Certainly it can be offered. As far as lactobacillus, this has been studied with great interest because of growing antibiotic resistance. There were 5 trials. There's not enough data to recommend. Certainly there were many trials with vaginal suppositories, which are not available in the US, versus oral, and crispatus is sort of one of the things to watch as far as the element in that. I'm sort of running out of time, so I got to move a little faster, but there was a really good study, good as in important and impactful for clinical recommendations. Increase water intake in healthy young women who have low water intake to start. So if they drink less than, if they have low water intake to start, they got randomized to add 1.5 liters or continue what you're doing for 1 year. They were able to reduce their UTIs significantly in 1 year's time. This is due to probably dilution and flushing, reducing nutrients for growth. This was funded by a water company, but I think it's certainly a reasonable thing to add. You can counsel them. Do your normal thing, add 1.5 liters of water a day. So, 2 liters a day would probably be reasonable. So patients are certainly open to this, and it does help. There's limited data on these other elements, so as far as the guidelines panel, they could not recommend. But these are things that patients come to you with, and certainly if they think it's helping and it's not doing harm, they can continue. Some of it, for example, methamphetamine, there just haven't been many studies. So, but if it's certainly useful and helpful in your practice, that's okay. There are probably, some promising therapies in here. Herbal therapies was very limited studies on intravesical hyaluronic acid. Biofeedback, interestingly, just biofeedback made people have less UTIs. And there's some immune therapies and vaccines in the future, but more studies to come. She does well for 2 months, then calls your office for acute onset dysuria. What now? You should get a culture and treat her. She asks for treatment. You're going to do first-line therapies, including nitrofurantoin, Bactrim, and phosphomycin. She's now coming back and saying, you know what, I want something else. What else can we do to prevent UTIs? So then we can talk about antibiotic prevention of UTIs. This is well studied. People can go on continuous therapy, low dose, trimethoprim, Bactrim, nitrofurantoin, cephalexin, or phosphomycin, or they can go on intermittent prophylaxis. This is generally, for example, for her episodes are associated with sexual intercourse, so she can do it around that time. What if she were perimenopausal or postmenopausal, and you do exams, she has vulvovaginal atrophy. The data on vaginal estrogen is very strong. There's been multiple randomized trials that decrease the incidence and time to recurrence of UTI. Systemic estrogen does not help this phenomenon, but if they're on systemic estrogen, you can add vaginal estrogen, and certainly if they have a history of breast cancer, you can coordinate with their oncologist. There's various formulations. There's no data to favor one formulation than the other. They're essentially equivalent. It has to do with their insurance and cost. And then there is another important one is that you should not treat asymptomatic bacteriuria in patients. A postmenopausal woman comes in, she gets a routine UA, it's positive, do you treat, do you not? There's data to show that they have poorer outcomes when asymptomatic bacteria is treated. So take-home messages: cultures are necessary. We should do as short a course as possible in order to limit collateral damage. We should do shared decision-making with our patients, and the management is focused on alleviating symptoms, preventing recurrence, and reducing adverse events. I'd like to acknowledge the entire guidelines panel and everyone involved. Thank you.